Hello, I'm Dr. Rajiv Agarwal, a practicing nephrologist, clinical trialist, and a biostatistician in Indianapolis, Indiana, USA. On behalf of my co-authors, including the investigators of Fidelio and Figaro DKD studies, I summarize in this presentation the results of the impact of albuminuria reduction with finerenone on future kidney and cardiovascular outcomes in people with chronic kidney disease and type 2 diabetes. Among 13,026 patients with type 2 diabetes and CKD, finerenone, a non-steroidal mineralocorticoid receptor antagonist, reduced composite cardiovascular outcomes by 14% and composite kidney outcomes by 23%. Finerenone also reduced urine albumin to urine creatinine ratio, which I will call UACR, a marker of kidney injury, within 4 months by approximately 30%. A meta-analysis of 21 clinical trials of various interventions and varying time for albuminuria measurements has found that a 30% reduction in UACR corresponds to 24% lower future relative risk for end-stage kidney disease. Although the association between UACR reduction and improved outcomes is well established, whether UACR mediates these outcomes remains unclear. Following randomization to finerenone or placebo, in this analysis, we measured reduction in UACR from baseline to 4 months and the outcome, kidney or cardiovascular, after 4 months. We then estimated the proportion of the outcome that was mediated by a reduction in UACR and the proportion of the outcome that was independent of UACR reduction. The distribution of UACR reduction from baseline to 4 months is shown here. Median reduction in UACR with finerenone at month 4 was 33.6%. In the placebo group, the median reduction was only 2.6%. Overall, cumulative incidence of composite kidney outcomes was lower in those with 30% or greater reduction in UACR compared to those who had less than 30% reduction. The same pattern was seen for composite cardiovascular outcomes. However, the magnitude of the difference was less. We will now examine the mediation effect by treatment for each of the two outcomes, kidney and cardiovascular. In the placebo group, cumulative incidence of composite kidney outcomes was lower in patients who had 30% or greater reduction in UACR compared to those who had less than 30% reduction in UACR. In contrast, for placebo-treated patients, the cumulative incidence of composite cardiovascular outcomes was similar regardless of the magnitude of UACR reduction. For finerenone-treated patients, cumulative incidence of composite kidney outcomes was lower in those with 30% or greater reduction in UACR compared to those who had less than 30% reduction. The cumulative incidence of composite cardiovascular outcomes was also lower in those with 30% or greater reduction in UACR compared to those who had less than 30% reduction. The magnitude of the mediation effect by UACR lowering differed by the outcome. When the reduction in UACR was analyzed as a continuous variable, it mediated 84% of the kidney outcome and 37% of the cardiovascular outcome. When the change in UACR was analyzed as a binary variable, that is, whether the guideline recommended 30% reduction threshold was met, the proportions mediated for the composite kidney outcome was 64% for the composite cardiovascular outcome, 26%. We conclude that among patients with chronic kidney disease and type 2 diabetes, early albuminuria reduction accounts for a large proportion of the treatment effect against CKD progression and a modest proportion of the treatment effect against cardiovascular outcomes. Whether this would hold true for drugs besides finerenone will require further studies. We hope that these data will motivate the increased screening and monitoring of UACR among patients with CKD and type 2 diabetes. We thank the participants and the families, the investigators, the coordinators, the monitoring teams, and the entire team at Bayer who carried out these studies. Thank you for your attention.